Good afternoon and welcome to the COVID-19 Research Seminar and the 15th in our COVID-19 research series, that is the Outcomes Research Seminar at North Shore. Today, Dr. Roy Perlis will be presenting his research on COVID-19 vaccine misinformation. We will also be joined by an expert panel, including Dr. Sharon Robinson from the North Shore University Health System, Dr. Natalie Watson from the University of Chicago, and Joseph Harrington from Capricorn. Next slide, please. So on behalf of the Outcomes Research Network, I would like to thank our expert panel. I'd like to thank Dr. Bernard Igman, the director of the Outcomes Research Network, and to everyone working on the front lines and in the fight against COVID-19. We would like to introduce as well Rachel Brewington, who is the administrator for the Outcomes Research Network, who will be co-piloting this seminar with me. And I'll just go over some background on the North Shore Outcomes Research Network, which is structured with key academic leadership, providing support to catalyze research across North Shore and the Institute for Translational Medicine academic communities. As well, the goals of our Outcomes Research Network are to enable uniform community access to care that is effective, efficient, and equitable, to enrich the practice of medicine, and to support key strategic clinical quality and operational decision-making. Our objectives for the series are to promote flourishing seminar principal investigators and to disseminate research activities and resources. We also want to promote a culture of collaboration and team science, and we want to bridge researchers to their peer communities across Chicagoland. Hopefully, we can deliver outcomes research that demonstrates improved patient and population health outcomes for our communities. Next, Rachel will be sharing a brief Zoom orientation to explain how to navigate the webinar today. Rachel.
Thank you so much, Dr. David, and hello, everybody. In today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on the screen. If you're on a computer, you can access this icon by hovering your mouse over the bottom of your Zoom screen. Please give special attention to the audience of your message before you submit it. As you can see on the image to the right, you can choose to message either the panelists and speakers, this will include myself, or you can choose to message everyone in the webinar. Feel free to leave your questions and comments at any point during the presentation. If you are experiencing any technical difficulties, please let me know by messaging all panelists and I will assist as best I can. Okay, thank you so much, Dr. David.
Thank you, Rachel. I'd like to go over an outline for the seminar. I had a video issue for just a moment there that I've corrected, excuse me. So overall, we're going to continue our introduction for the first few minutes. Following that, we will have our presentation from Dr. Perlis, and he will present until about 3:40. During that time, I'd like to welcome participants to submit comments in the comments box, as well as questions, and we're going to provide those to our speaker, Dr. Perlis, during the Q&A session. Following that, we will have the Incubator Hub expert panel discussion, where I'll have an opportunity to introduce our honored guests, Dr. Sharon Robinson, Mr. Joe Harrington, and Natalie Watson. And we will also be welcomed by the speaker to go over the implications of this work for health equity, for clinical implementation and dissemination, policy, and future research. And after that, we will have some closing remarks. So I would like to introduce our speaker, Dr. Roy Perlis, who is a psychiatrist and director of the Center for Qualitative Health. He's also a translational scientist at the Massachusetts General Hospital and Harvard Medical School, and as well as a professor. And he is going to present today on his work evaluating COVID-19 misinformation. And Dr. Perlis, welcome to the Outcomes Research Seminar.
Thank you so much. And thanks for giving me the opportunity to speak to you today. And I want to emphasize we have a fantastic panel. So really, I'm just the warm-up act. But what I want to talk to you about in the next 30 minutes or so is work that we've been doing over the last 2 years to try to understand the relationship between COVID-19, mental health, and misinformation in the United States. And as Dr. Dave mentioned, I spend much of my time in the wet lab working on neurons and microglia. But when COVID arrived in spring of 2020, I was fortunate enough to start working with a group of colleagues on a 50-state COVID survey called the COVID States Project. Could I have the next slide, please? So the COVID States Project is a survey that we administer about every 8 weeks to about 20,000 US adults over the internet. And it's a collaboration across multiple universities. You can see them on the bottom of this slide. And the idea is really to understand a few things. It's how do people think about COVID? How are they behaving in relation to COVID? And then more broadly, how do those behaviors and beliefs relate to other kinds of attitudes, other kinds of actions? How do they relate to where you live, what your politics are, what you do for work or don't do for work, or where you go to school? So really trying to understand at a very high resolution level. So again, across all 50 states and the District of Columbia, how is COVID affecting us and how are we affecting COVID? Could I have the next slide, please? So just to get a sense of the scope of the problem, in our survey, we ask participants about 4 specific items of misinformation related to COVID vaccines. And we've been doing this for now multiple waves for more than a year. And when we give them those 4 statements and ask, is this statement true? About 1 in 5, so nearly 20% of the people who respond to our survey will tell us that at least one of those items is true. And about 4 in 10 on top of that will tell us they're not sure about at least one of those items. So when we give people 4 items of misinformation, more than half of the survey respondents either say that they're true or that at least one of them, they're not sure if it's true. That fundamentally is a challenge for those of us in public health who are trying to respond to COVID, and in particular, trying to encourage people to get vaccinated. Can I have the next slide, please? So these are the specific questions that we ask people about, and I try not to even go through them in too much detail because I don't want to make the mistake of someone misreading this and thinking any of these are true. They are unequivocally false. There is abundant data telling us they are false, and we've known this for quite some time. And yet, when we show this to survey respondents, adults 18 and older, about 10% for the top 2 and about 5% for the bottom 2 will tell us that they're true. And again, in many cases, more than 50% will say they're not sure, which is perhaps less concerning, but still somewhat concerning, given how much effort has gone into educating people about COVID vaccines and the safety of COVID vaccines. You might think that these numbers would have moved a lot from the fall of 2020 when we started asking to the present, but unfortunately, there's still fairly high rates of misinformation in the community. Next slide, please. When you ask people why they haven't been vaccinated with a vaccine that we know to be safe and highly effective, and just as an aside, before the vaccines were available, when we were starting to frame questions for people about vaccine effectiveness, we used to ask, if a vaccine were 50% effective or 60% effective in preventing COVID complications, would you get vaccinated? We had no idea that the efficacy of these vaccines would be nearly as good as it has proven to be. With just a useful reminder that we've been fortunate to have vaccines that are far more effective than we ever thought. And yet there's still a substantial proportion of the population that has chosen not to be vaccinated. And when you ask them in our survey, why not? They often say things about trust, not trusting the government, worrying about side effects. We can drill down a little bit more. Could I have the next slide? So if you ask people, why aren't you vaccinated? About a third will tell you they're concerned about the risks of the vaccine. And these are examples of when we ask people to just write a comment about what they're worried about. And what you tend to notice is that it's not that these are completely false in the sense that it's not that this is never on the news or never reported. It's just that people's understanding of these risks tend to be disproportionate. Next slide. About a quarter will tell us that it's just too soon to tell. And this number's gone down a little bit, but really, even with more than a year of experience with these vaccines now, there's still a high proportion who tell us it's just too soon to tell. And this is an example that, are we going to find out later on that this is really less safe than we thought? Next slide. About 15% will tell us they just don't trust authorities. And this is really a notable observation during COVID. I think in the past, there were certain authority figures, particularly in public health and in science, where rates of trust were quite high. And that's really not been the case during COVID. And that these are examples, not that there aren't good reasons not to trust authorities. And I think some of these comments reflect the fact that there are real concerns about, certainly in the past, certain public health actions or certain government actions, but about 15% will tell us, this is the reason I'm not being vaccinated. I don't trust the authorities. Next slide. We need to put this in context. Americans do love conspiracy theories. We are conspiratorial thinkers, and this goes back long before COVID. So it's not necessarily a new development. It's just that COVID, as in so many other areas of life, has sort of compounded underlying aspects of American society. There's a nice commentary by two of my colleagues on the COVID states survey that goes into this in more detail. But one of the points that they make in the survey and in the commentary is that if you ask Americans about whether the moon landing was faked, or whether there are aliens being housed in the United States, or whether 9/11 was an inside job, a remarkably high proportion of people will tell you, yeah, I believe that conspiracy theory. So conspiracy theories and willingness to embrace misinformation goes back long before COVID. It's not our topic for today, but I do think there's a lot of value in thinking about social media, and we may come back to that in our discussion at the end, because I think what social media has tended to do is catalyze rapid dissemination of this kind of misinformation in a way that might not have been as efficient prior to the availability of these kinds of platforms. Next slide, please. Speaking of conspiracy theories and misinformation, it's worth pointing out that COVID misinformation and vaccine misinformation is not the only kind of misinformation that flourishes on the web. So in our survey, we also ask people about Ukraine and the war with Russia. And there's widespread misinformation about what's going on in the war and why the war is going on and the reasons for the Russian invasion. One of the things we've observed in our survey is if you draw a Venn diagram of COVID misinformation and Ukraine misinformation, there's a large intersection. So there are a lot of people who do hold both sets of misperceptions or misbeliefs, but there are large portions of each circle that don't overlap. So they're not all the same people who believe these things. Next slide, please. If you ask where this misinformation does come from, I've already sort of tipped my hand and mentioned social media. So in our survey, we go back and we ask people, in addition to asking them these questions about COVID vaccination and belief in misinformation, we ask them, well, where do you get your information, whether it's for COVID or for Ukraine? One of the striking things is how often podcasts show up in people who believe misinformation, as well as certain websites or certain apps. Those seem to be, and then instant message or messaging systems, whereas more traditional sources of news, print newspapers, local TV, cable TV, network TV, tend to be a little bit less common as sources of misinformation. So really just sort of further reinforces how certain internet platforms and social media may contribute to the spread of misinformation. Next slide, please. I think a critical point when we talk about things like social media, though, is realizing that just pushing back on misinformation doesn't necessarily correct the problem. So, for example, I spend a lot of time maybe not a lot of time, certainly too much time, reading discussions about COVID on social media in terms of public health. And one of the things I notice is there's a lot of effort to push back on misstatements on things like Twitter, right? So, or even Facebook. So people will say, no, you're wrong about that. Actually, this is true. And the challenge with that is that telling people they're wrong does not necessarily change their mind, right? And in fact, one of the experiments that we've done in our survey is you ask people how confident they are in their knowledge about vaccines. You give them these questions about that reflect vaccine knowledge or misinformation, and then you tell them they're wrong. So you go back and you say, well, actually, that's not true. Actually, this is true. And you might expect that that would diminish people's confidence, right? You took a quiz essentially and you got the answers and were told that some of your answers were wrong. You might think that would decrease your confidence in your knowledge. Turns out it doesn't change your confidence at all. Okay, so it's not to say that we don't have an obligation in public health to push back on vaccine misinformation. I think that's part of the solution, but we have to recognize if we're going to develop successful public health responses to increase vaccination rates, just telling people they're wrong or just giving them the correct information may not be sufficient. And in some cases may even push people in the opposite direction. Next slide, please. So I've been talking about misinformation as if it matters, right? So I jumped right into the middle of here's how common it is, up to 1 in 5 when it comes to vaccines. Does it matter, right? Maybe this is not necessarily a problem. Next slide. So unfortunately, one of the things that we observe, which is not terribly surprising, is that if you believe vaccine misinformation, you're much less likely to be vaccinated. So if you don't believe misinformation, about 80% of the people in our survey several months ago had been vaccinated. If you believe one of these statements, you're about 50% likely to be vaccinated. And if you believe 2 or more of these misinformation statements, you're only about a third of those individuals are vaccinated. So huge impact on whether or not people get vaccinated, not surprisingly. If you believe that vaccines are not safe, or if you believe that they might cause harm in some way, you're much less likely to go along with vaccination. Next slide. When we go back and do this in a more systematic way and adjust for other differences between people, so maybe misinformation is just a marker of something else, when you adjust for these other potential confounders, we still see very large effects. So if you believe misinformation in our survey, you're a lot less likely to be vaccinated. You're a lot less likely to tell us that your family members are vaccinated, and you're a lot more likely to tell us that you're resistant to getting vaccinated. So not just that you haven't had a chance or you don't know where to go, but you're not planning on getting vaccinated at all. Next slide. Why are we so susceptible to misinformation? Well, I've already told you to begin with that this goes back to before COVID. So I think there probably are aspects of American society that contribute to this receptiveness to misinformation. That's maybe a story for another time, but the substrate is there for us to be susceptible to misinformation. Next slide, please. I want to talk to you about some of our work specifically related to mental health. And to do that, I have to tell you a little bit about what we call a negative cognitive bias. So sometimes you might hear people talk about viewing the world through rose-colored glasses, right? You think everything is maybe a little bit better than it actually is. But there's a flip side to that, which is viewing the world through what you might call dark-colored glasses, where everything's actually a little worse than it actually is. And we know that this negative cognitive bias, this seeing the world through dark-colored glasses, can be a consequence of depression, and it can contribute to depression. Okay, so people who are depressed tend to see the world more negatively, and people who see the world more negatively may be at elevated risk for depression. So as a psychiatrist, I'll tell you it's a complicated relationship, But what we can say with confidence is depression and this negative bias tend to travel together, such that we think people who are depressed may be more likely to pay attention to or to absorb negative things about the world. Again, you see the world as a more dangerous or more negative place. Next slide. And unfortunately, during COVID, there's been a lot of recent attention to children, but in adults as well, the rates of depression are markedly elevated compared to what we saw before the pandemic. And when I talk about depression, I'm talking about symptoms of major depression as measured by a scale like the PHQ-9, Patient Health Questionnaire 9, which is used a lot in primary care as a depression screen. So in our survey, we happened to build in this depression screen. Prior to COVID-19, when you surveyed the population, rates of depression tended to run about 8%. So if you gave this instrument to a random subset of adults in the US, about 8% might endorse symptoms of moderate or greater depression, a level where we might refer someone for treatment. During the COVID pandemic, these rates of depression have run anywhere from 20% to more than 30% among adult populations. So far more common than pre-pandemic. Does that mean all these people need to be treated? Absolutely not. But what it does indicate is there's a lot more depression during the pandemic. Again, not surprising, but still important to quantify. Next slide. This bar graph just illustrates sort of rates of depression in our survey. So about half the people we ask really don't endorse any symptoms of depression. Another quarter have some mild depressive symptoms. Maybe they're having a bad day. But in our most recent survey, 26 or 27%, so about 1 in 4, told us they had sufficient levels of depression that if they went to see their primary care doc and filled out that depression screening form, the PCP would say, you know, we might think about whether we want to get you an evaluation or even start some kind of treatment. Next slide. I would say, to my mind, one of the most striking findings in our survey has been the way we consistently observe differences in the rate of depression by age group. So we survey a representative sample of US adults in every wave, around 20,000, as I said. And representative means we're looking across race and ethnic groups, we're looking across age groups, we're looking across genders, we're looking across regions. So we work very hard to get a representative population. And what we see consistently is that the greatest rates of depression are in young adults, in the 18 to 24-year-old crowd, followed by the 25 to 44-year-old group, and then the least depression among the 65 and older group, although even in that older adult group, rates of depression are substantially higher than pre-pandemic. Now, by the way, at least as of 5 to 10 years ago, we really did not see this sort of stair step or this increasing rate across age groups. So if you go back a decade or even about 5 or 6 years, there really wasn't this marked difference by age group. That may well be a more COVID specific effect, although my suspicion is it was starting to creep up in that younger group even before COVID. We just don't know. Next slide. I should point out that while we see this in our survey, we're certainly not the only ones. There are a number of other surveys using different methodologies that find very similar results. So for example, this is Kaiser survey data. Again, if you just look at the mental health line, you see this effect where it's largest in 18 to 29 and then gradually diminishes, although still at really historically high levels in older adults. Okay, so take home from this, depression widespread, greatest in young adults, but elevated across the population. Next slide, please. The other observation during the pandemic, because we are in the field every 8 weeks or so, we can look over time at how these rates have changed. And I remember being very surprised when we got the first results in June of 2020 at how high they were and thinking, well, They're bound to get better. And really, despite changes in the pandemic, despite changes in the political environment, which we thought might be driving some of the depression, at least in particular subgroups, rates of depression have remained quite high, and the differences by age have remained remarkably consistent as well. Next slide. Lest you think that like nothing ever changes over the course of our survey, one glimmer of hope is that we have seen changes, for example, in rates of depression among parents versus non-parents. So this is looking at rates of depression comparing parents with kids at home versus people who don't have kids at home, showing that while there was a quite sizable gap earlier in the pandemic, while the gap hasn't closed completely, it's gone from about a 10% difference to now less than a 5% difference. And one obvious contributor to this, of course, is the return to school in most cases. So we do see changes over time. We're pretty sensitive to change. It just, in general, levels of depression have remained stubbornly high. Next slide. So why did I start by telling you about misinformation and then spend so much time talking about depression? Well, as a psychiatrist, my curiosity was, might depression be contributing to these rates of misinformation that we're seeing in our survey? And this is a paper that was published earlier this year in JAMA Open. I'd encourage folks to delve into the details if they want, but I'll give you the bottom line, which is we did observe a strong association between people endorsing symptoms of depression and endorsing misinformation related to the COVID vaccines. Next slide, please. Now, there are lots of differences between people who do and don't endorse misinformation, and lots of differences between people who do and don't endorse depression. So we can use statistical models to try to untangle that, to say how much of this are differences in age, or differences in gender, or education, or race and ethnicity. And I'll give you the punchline of this paper, which is that after you account for those things, people who were depressed were substantially more likely to endorse misinformation. So the two traveled very closely together, even when you got rid of the effects of other differences between these two groups. Now, this is a correlation. It doesn't tell us that one is causing the other, and that's a limitation of these kinds of studies. So it's a cross-sectional analysis. But what we did try to do is get a little bit of a handle on which came first, the depression or the misinformation. And again, a survey is not a perfect way to do that, but we took advantage of the fact that many of our survey participants complete one survey and then come back on a subsequent wave 8 weeks later, 3 months later. It's not necessarily the next wave, but people come, we see them more than once. And so we asked the question, does depression precede misinformation? In other words, if you are depressed on one wave, are you more likely to endorse more misinformation on a subsequent wave? It still doesn't show causation. It still doesn't show that the depression is causing people to absorb misinformation, but it's at least suggestive that that might be the direction that things are flowing. Next slide, please. And in fact, if you endorsed depression in one of our surveys and you came back later and filled out another survey, you were indeed more likely to endorse more information. So people who were depressed the first time we saw them, when they came back, were more likely, all other things being equal, to believe more information, to misinformation, to absorb more of it. So again, I still can't tell you that depression causes misinformation. I think the relationship is more complicated than that. But given how common depression is in the US right now, it's at least another handle we might use, or another angle we might take in thinking about how do we push back on misinformation. Next slide. I already told you this, but I'm going to show it to you again, just to remind you, misinformation matters a lot. So people who endorse misinformation are less likely to be vaccinated, less likely to have vaccinated family members, more likely to be resistant to vaccination. So is it possible that if we did a better job identifying and treating depression, we might make some headway against misinformation? I don't know. At this point, that's a hypothesis, but it's one that I would argue probably deserves more thought. Next slide. We're not the only ones who've raised concerns about the effects of depression on pandemic behavior. So there's a nice paper that appeared about a year ago showing that people's sense of paranoia had also increased during the pandemic, particularly in the context of being locked down with COVID containment methods. So it fits into a larger picture that says people are more anxious, they're more depressed, and frankly, a little more prone to see the world as a dark place during COVID. And I think our hypothesis is that that probably impacts their willingness to absorb and believe misinformation. Next slide. So I want to shift gears and in the last few minutes, talk a little bit about where we go from here. What does this actually mean for society more generally, not just in terms of COVID? Next slide, please. So I want to emphasize COVID didn't cause depression. It didn't cause mental health problems in general per se. What it did is exacerbate these pre-existing fault lines in mental health. So we already had high rates of untreated or undertreated depression. It just increased those rates. We already had problems with access to mental health care. It just exacerbated those problems. We still find that any sort of medical illness has a disproportionate impact on people with psychiatric illness. I do think our failure to invest in mental health impacted our ability to respond to the pandemic, and our failure to invest in mental health has certainly impacted society more broadly in terms of pandemic response. Next slide, please. Just as a historical note, we had a commentary that appeared in early spring 2020 about managing COVID-19 and made the point that we had to worry about burnout, and not just burnout about healthcare workers, but burnout more broadly. I think unfortunately subsequent events have borne that out. But the other reason I show it to you is in the spring of 2020, it was still possible to believe, well, maybe this would stay contained to Wuhan or to China more generally. Obviously, things didn't work that way. Next slide, please. So why do we see so much depression? Let's take a step back. One of the major reasons we think we see so much depression are the economic consequences of COVID-19. So very early on, whether it was losing a job or falling behind on a mortgage, you can't lose sight of how much COVID impacted people in terms of financial security. The flip side of that is some of the early actions to try to buffer those economic consequences may also have been among our most potent mental health interventions. So trying to protect people from the financial or the economic consequences. Next slide. Another reason that we've been hit so hard, I think, with mental health consequences during COVID is the impact on parents in particular and the impact on children. So the Surgeon General of the United States had a really thoughtful report on COVID's impact on children, but said very little about the concomitant impact on parents and teachers, which I suspect has been a huge knock-on effect of COVID. So it's not just the kids with these consequences, it's the adults who have to take care of these kids who suffer the consequences. Next slide, please. I also think we can't underestimate the effects of social isolation during COVID. So this is additional data from the COVID States Project, not yet published, but really striking effects, in this case among older Americans, of loss of social support, loss of social networks on people's risk for depression. So in normal times, our social networks help buffer stress, right? They're a way that we are more resilient against the things that happen in daily life that might contribute to depression. One of the reasons COVID has been such a perfect storm is not only is it a massive source of stress, but it disrupts the very networks that we would ordinarily rely upon to protect us against that stress. Next slide, please. Just as a little bit of a curveball, I should point out that we've consistently seen greatest rates of depression among independents and Democrats in our survey. We do ask about political affiliation. I'm not going to say too much about that, but there are lots of ways in which COVID has affected different groups in the US differently. Next slide. The other concern that I just want to raise is our data and others shows that risks of depression are increased among people with prior COVID. And the symptoms of depression may be somewhat different, or at least a little bit different among people with prior COVID compared to those without. So what remains to be seen is the extent to which, in addition to the pandemic more broadly and the societal stressors causing people to be at greater risk for depression, COVID infection itself may increase longer-term risk of depression. That's very much a work in progress. Next slide, please. This is just an illustration of that point. It's from some work that we published about a year ago, showing that if you look at how long ago someone had COVID-19 and how likely they were to tell us they were experiencing symptoms of depression, everyone with prior COVID seemed to have an elevated risk of depression. The risk seemed to peak in people who told us they'd had it about 8 or 9 months ago. Next slide. I want to switch gears here and talk a little bit about, again, sort of where we go from here, why this might matter from a policy perspective more broadly. Next slide. One concern with the increase in depression is, of course, suicide risk. But I should point out as a psychiatrist that the greatest risk or the greatest consequences of mental illness are in their chronic impact on people's quality of life and functioning and their impact on other medical illnesses. So it's not to downplay the importance of suicide in terms of a consequence of mental illness. It's just to point out there are actually lots of ways that we need to worry that depression and related disorders are going to impact long-term quality of life. Next slide. Maybe the most obvious one is that even though we have not seen an elevation or an increase in suicide among adults, we have absolutely seen an increase in both drug and alcohol associated deaths. This is CDC data showing pre-pandemic, and without even telling you when the pandemic starts, you just by eye from 20 feet away can see when the pandemic starts because the rates of both drug and alcohol associated deaths spike. Next slide. I mentioned access and the fact that COVID has exacerbated underlying disparities that predated the pandemic. There's CDC survey data from early in March that shows about a quarter of those who report depression and anxiety said they felt like they needed treatment but couldn't get it. And overall, about a quarter said that they had gotten some kind of mental health treatment in the prior 4 weeks. So I show you this just to make the point that not only do we have really unprecedented levels of depression and anxiety in the US during COVID, we continue to have major problems with access. So even if we can identify depression, we don't necessarily have sufficient resources for people to get treatment. Next slide. Whenever I talk about depression, anxiety, suicide, I always throw up a slide like this. There are hotlines that will provide an acute intervention. In other words, if someone's feeling this way, there are absolutely places that they can call. I think our real challenge is what happens next, figuring out how we get these people from calling a hotline into an actual clinical referral. And that's very much something we as a society need to think about, not just in the context of COVID, but more generally in terms of how we approach mental health. Next slide, please. I want to end by talking a little bit about, I know this is part of a broader series about COVID-19. I think in grading how we as a society, and in particular, we as a government have responded to COVID-19, I guess I would characterize the response as better late than never. So unfortunately, the new administration didn't include a psychiatrist or a psychologist on their COVID transition team. They remedied that somewhat by adding someone with a background in mental health nursing, but I think it did reflect initially dropping the ball a little bit. It took them a very long time to comment on mental health. It was really not until December when the Surgeon General issued his report, although I would commend that report to you. It's really thoughtful and important and lays out an agenda, at least among children, in terms of how we can approach mental health. And I should say the administration has definitely invested in mental health services, especially at the state and local level. So we know they care about it. I think I would like them to spend a little more time talking about it because both are important. As I said, they have invested in it in terms of block grants and in terms of their new budget. So it's not that they're not paying attention. I think they are, but I think what we as a community can do, not just to maybe start to address misinformation, but more generally to deal with these rates of depression, is to start thinking about where we invest our energy and how we talk about things like depression and anxiety. Next slide. Most recently in April, there was a presidential memorandum that finally really acknowledges how much of a mental health crisis we're dealing with in parallel with the pandemic itself. And I do think belatedly beginning to not just walk the walk, which is important, but talk the talk and acknowledge how we need to address mental health as part of our COVID-19 response, not just in children, but in adults as well. Next slide. I've talked about a lot of kind of uncomfortable or unhappy things. I want to close by saying I think there's a lot of reason to be hopeful. I think the administration has started to engage. I think we're starting to understand what needs to be done. It's not a question of, this is not one of those. The former NIMH director, Tom Insall, has a new book out, and he makes the point really beautifully. It's not that we don't know what to do for things like depression and anxiety. And I think, I hope I've convinced you that there's good reason to make these kinds of interventions. It's really just having the will as a society to invest in mental health, to talk about mental health, and to understand that part of the COVID-19 pandemic is its direct and indirect effects on mental health. We see it in COVID misinformation and willingness to be vaccinated, and we see it more broadly in people's functioning and their quality of life. Next slide. I want to close by, again, thanking North Shore for inviting me to speak with you, thanking our panelists in advance for what I think will be an interesting discussion, and thanking all of you for joining today. So thanks very much.
Thank you very much, Dr. Perlis. I'm going to hand this over to Rachel.
Thank you so much, Dr. Perlis. It's time for our question and answering portion. At this time, we'll take your questions. As stated earlier, please input your questions in the chat box by addressing it to panelists and attendees so everyone can be involved. If all questions are not addressed, please feel free to contact Dr. Perlis at his email address shown on the screen. Okay, we have a question right now. I'll start. Do you think that differences in misinformation and trust in government by different demographic groups was impacted by different rates of depression?
It's a great question. So I think the first key point in responding is that we have to acknowledge that this is not a problem with a one-size-fits-all solution. So we need to respond to misinformation probably differently in different groups because they come at this with different perspectives. I think the relationship between misinformation and depression is probably bidirectional, in the sense that I do think different rates of depression in different groups impacted receptiveness to misinformation. I also think some of the same factors that contribute to absorbing misinformation probably contribute to depression risk in general. Differences in education, differences in income, frankly, responses to racism and structural racism. I mean, there are lots of differences among groups that impact both risk for depression and probably receptiveness to misinformation. So one size does not fit all. And I think one of the things I've come to appreciate in working on this survey is, we're a remarkably diverse society. And as a scientist, sometimes it's tempting to say, well, here's the solution, right? Here's the cure for this disease. I think when it comes to misinformation, we need a lot of different kinds of cures, and we need to be thoughtful about the communities where we're trying to deploy these responses.
Okay, thank you. Next question. Has there been an increase in gun violence? The question is prompted by the reported murder-suicide intentions of the Buffalo killer, but more broadly, the news seems to point that way.
Another excellent question. There is, I should say at the outset, there is a correlation between depression and anger, and depression and irritability. So when people feel lousy, some of them will respond with more anxiety or social withdrawal, and some with more anger. So as I said at the beginning, the substrate is there. People feel lousy, and the way that feeling unwell is manifest varies a lot. That's, by the way, not to say that necessarily contributes to gun violence or to violence in general, except CDC has reported an increase in violence and gun violence. So I do think that there's a relationship between COVID and probably COVID is sort of COVID-associated stress and increased rates of gun violence. So I think the answer to that, unfortunately, at least based on CDC data, is yes, there's probably a relationship there. I guess we also know that most societies have not seen this kind of an increase in gun violence. And so I would be remiss if I didn't point out that we're a society where it's awfully easy for people to access guns. And so in thinking about solutions to this problem, we probably need to be thinking hard about the access side of things and the regulation side of things as much as anything else.
Thank you. Here we have a comment. Interesting, the relative low level of depression among political conservatives versus liberals, but at the same time, the depression relationship with belief in misinformation.
Yeah, it's part of the reason that we try to use regression and sort of more complicated models to understand how misinformation and depression were related, because again, it also, there are so many other things that track with depression or with misinformation. We've certainly seen through the whole length of the survey that independents in particular, but also people who identify as Democrats tend to report higher levels of depression. I remember a quote about, if you're not outraged, you're not paying attention. That might account for some of that, but I'm not a political scientist, so I can tell you we've consistently seen that association, but I'm probably not the right one to speculate about why we see it.
Next question. And I wonder, did you touch on this already? I am curious about the rates of depression sorted by political orientation. Can you comment a little?
Yeah, I think political affiliation and ideology is sort of, it's capturing a lot, it's capturing differences beyond politics. So I don't know that it's politics per se. It's probably politics as a marker for, I am in a particular kind of community, or I'm surrounded by a certain kind of people where particular beliefs might be more or less common. But again, I'd leave it to the political scientists to understand why we see such a gap in depressive symptoms.
Next question. The one graph showed the group with some college was more likely to believe in misinformation. One would think the more educated would be less likely to believe in misinformation.
Absolutely. I think what I take away from this is that education is absolutely not perfect protection against misinformation. And, I think naively, when we started doing the survey, I thought, not knowing anything about the topic, I might have said, yeah, it's just, people who aren't educated or people who aren't knowledgeable, right? I mean, and I think we make a mistake when we do that. Because again, there are lots of reasons people who are otherwise educated, well-informed, believe misinformation. And unless we kind of get into those weeds, we can't get away with these broad generalizations. So it is absolutely true. There are plenty of people in our survey with advanced degrees who absolutely endorse misinformation.
Next question. What would you suggest telling someone who was told by her MD that she shouldn't get the second booster because it could lead to liver problems? The person who was told this is an 85-year-old RA and MIA lung disease.
It's so hard. I mean, it really, just about every day I hear stories like this. And, my doctor said this, or my cousin said this, or, a lot of misinformation, interestingly, seems to be spread by people who have, my friend's friend is a doctor, my friend's friend is a nurse, my friend's friend is a radiology technician. So that seems to be a really common way that misinformation spreads. And, having some health experience or health exposure doesn't necessarily make someone an expert in COVID-19. I mean, look at some of the information that's been spread by Dr. Oz about COVID-19, right? I think, unfortunately, it's more toxic because people are inclined to believe MDs or other people who work in healthcare. So unfortunately, that's not the first time at all that I've heard stories like this. What doesn't seem to work very well in general is, no, you're wrong. What can work better is to say, that's interesting because what the CDC said was this, or what I saw on the American Medical Association website was this. And so not necessarily confronting someone and saying they're wrong, but gently introducing additional information from a different authority. Again, in the past, I think from a public health point of view, the fact that there were authorities who were fairly widely accepted as reputable sources made this process a lot easier. NIH says this, CDC says this, the Surgeon General says this. We live in an era where the Surgeon General of Florida can say outrageous things and not necessarily be called on it. So, we have problems with sort of single authority figures at this point. But again, my response is usually to just gently direct people towards more reputable sources of information.
Thank you. Okay, we have about 2 questions before we move on. You mentioned that telling someone they're wrong, at least on social media, isn't an effective way to change their beliefs. And you just touched on this, but do you have data on what works? Example, some people have moved from vaccine hesitant to getting vaccinated. Do we know what factors seem to lead to this?
I love that question. And I would say that's something we're working on, is trying to understand, how do you move somebody from all the way from resistant to vaccination to getting vaccinated? I think a lot of the emphasis, at least so far, is moving people from vaccine hesitant to vaccinated. So there's still a big pool of people who aren't sure in our survey about getting vaccinated. And they may be the ones where we have more opportunity to move them in a direction of getting vaccinated, right? There's still, it's sort of like the people who say they don't know about misinformation rather than the ones who say, I believe this misinformation. There may be some opportunity to change their minds. But I don't know the best way to move people in that direction. There's a lot of work in trying to understand that, and an opportunity to, I think there's work going on in thinking about who the messenger should be. So a single messenger, you can't necessarily have a single messenger for all communities, for all perspectives. You may want different messengers, different authorities, depending on who you're speaking to. That's probably pretty important. You can't just show up and say, we're from the government, we're here to help you, right? I think building trust can take time. But I think it would be a mistake for me to suggest that we can't change people's minds. People change their minds all the time. And we need to maybe get a little bit smarter. We know what doesn't work all that well in terms of telling them they're wrong. We have some work to do to figure out what works better than that.
Thank you so much. All right, that's all the time we have for questions. Please feel free to insert any additional questions in the chat box for our presenter to review later. I know I didn't get to everyone, and then he will be able to answer your questions at a later time. I will now hand it over to Dr. David, who will introduce our expert panelists for the Incubator Hub panel discussion. Thank you.
Thank you very much, Rachel and Dr. Perlis. Really a brilliant presentation and a lot of very evocative. We have a lot of questions, great questions, and there's more coming up. So we just need to move on to the panel. And so I'm really excited today to welcome our expert panelists. We have 3 expert panelists who will provide some additional insight to the implications of this research presented. The first, we have Dr. Sharon Robinson, who is the Assistant Dean for Diversity and Inclusion at North Shore University Health System. She's also a senior clinician educator at the University of Chicago Pritzker School of Medicine. We have Natalie Watson, who is a community relations program manager for the University of Chicago Center for Community Health and Vitality and the Institute for Translational Medicine. And we have Joseph Harrington, who is the co-lead for the Patient and Community Advisory Committee, PCAC, and project lead for the PCORI-funded Patient Engagement Project, elevating the patient voice in research. He's also president and CEO of the Mojo Group. And again, we're welcoming Dr. Perlis to also join our panel. So thank you all very much for joining us today. Next slide, please. So having listened to that really interesting and complex presentation, I'd like to ask the panel to reflect on the implications of this research for health equity. And understandably, this is a multidimensional question because there's a lot of health equity that was raised in the research, but also where do we go from here in terms of addressing the inequities in access to resources, testing, but also addressing some of the misinformation across our United States with all of its diversity, and also some, trust issues with the government going back to the American Revolution. So if some of you could address the health equity implications.
Well, I'll start with that easy question, Sean. First of all, thank you so much, Dr. Perlis, for an excellent presentation. Very provocative and a lot to think about. There's so much to talk about with health equity and how this relates to everything that's going on. I think I'll just, focus my initial comments on some of the mistrust and especially how that plays a role in Black America and what's going on with COVID and vaccine hesitancy there. I am sure that everyone on this call can understand how and why, I hope at least, this mistrust exists. We need to look no further than what happened on Saturday and the tragedy in Buffalo to just understand how vulnerable and unsafe so many of us feel. And that really spans across the gamut in this society, including, unfortunately, healthcare, because of historical issues and racism and mistreatment of Black bodies. I really liked what Dr. Perlis said about the way to approach folks who have mistrust. I think one of the first lessons that I learned early on, especially with the COVID vaccine hesitancy, was to ask questions first before responding. So, for example, before launching into this whole thing about, I'm sure that you're hesitant because of the Tuskegee experiment, but this is why this is different. Did you ask the patient or the person if the Tuskegee experiment was the reason why they were hesitant about the vaccine in the first place? I think we make a lot of assumptions about why people are hesitant or why people believe misinformation. So asking questions and really seeking to understand is critical. Meeting folks where they are and then trying to move the needle from there. In addition to my role as Assistant Dean of Diversity, I'm a pediatrician. I've practiced for over 20 years. And so I've had lots of conversations about vaccine hesitancy. And I have found that that's one of the best approaches, is to really understand what are the issues, what are the concerns, and then try to carefully and thoughtfully address them. I think when people come to me with things like the infertility question, which came up a lot, especially for parents of young girls, is when the vaccine became available for 12 and up. The way that I would respond to that is like exactly how Dr. Perla said. I would say, that's really interesting information. That's really interesting. I have not seen any study or paper that supports that. Can you direct me to where you found that information? And it's not in in a patronizing way. It's just out of like a curiosity way. And sometimes that helps those folks understand that, because they stop and reflect. They're like, oh, wait, I saw this on my Facebook feed. It really wasn't in a scientific journal. And so then that can help them start to do a little bit of the work and to recognize that, oh, perhaps I need to look at my sources of information a little bit more closely. So I think those are a couple of examples of the ways that I've tried to address this. But I think we just have to acknowledge that we have a lot of work to do in this country. And we have harmed marginalized groups of folks in this country for as long as we've been in existence, and we continue to do it. And so we have to address some of these other issues like gun control and this systemic racism at the same time, if we really want to see positive change when it comes to something like COVID vaccination rates.
Thank you. That was such a thoughtful response, and I really appreciated how you approached that patient. And thank you so much. Natalie, I wonder if you could comment on some of the health equity implications of this work.
Yeah, so going back to what Dr. Robinson mentioned, not being afraid to have the conversation, right? Asking questions, but also acknowledging that some of the things that many of those who are vaccine hesitant, in particular around the COVID-19 vaccine, because what I have found is that many of our Black and Brown people are not hesitant against other vaccines, this particular vaccine in general, because the lack thereof it's new, right? And it speaks to many of the atrocities that have happened to Black and Brown people within the healthcare system. And oftentimes we are afraid to acknowledge that many of the things that they speak of have happened, right? And so being able to engage in those conversations and then move into the conversation of why, of what are the facts that you have just mentioned, what are the scholarly articles, or what website did you get this information from? But what I found is once you've built trust, right, with those that are hesitant, and oftentimes I'm mainly speaking to many of the communities that we serve, and with the programming that I work with, which are Black and Brown communities, it's all about the trust factor, right? And building that trust to be able to even have a conversation where they, would be willing to consider what you are saying, right? So oftentimes, I work for the University of Chicago Medicine, right? I've built over the years trust with many of our community members, and I'm from the South, my family's from the South side of Chicago, and I had to do the work, right? So just because I look like them does not mean that they trust me, right? But I had to do the work to be a trusted person within our community. And just, acknowledging that many of their thoughts are real and many of their beliefs are real, but also acknowledging that COVID-19 is real and it is harming our community. And, many of them have loved ones that they've lost, right? And asking the question. And another thing that I, that comes up a lot is, acknowledging that we did not do a great job about being transparent, about the vaccine, right? So when we were initially, talking about the vaccine or information was provided, it was, if you get vaccinated, you will not get COVID-19, right? And although that is not truly what was said, and if you are knowledgeable about healthcare and how vaccines work, we knew that getting vaccinated meant that it will likely keep you alive. But many of our community members heard that if I get vaccinated, I won't get COVID, right? And then their friends got vaccinated and they got COVID, right? So then it's like, here we go again. Here, this feeds the conspiracy of, you told me if I got vaccinated, I wouldn't get COVID-19, right? And so it's just about the transparency and how you deliver that message. And because I say that because I've been asked that question many times. And what I do is I acknowledge, what, we did a really bad job in the beginning, delivering the message. And yes, if you get vaccinated, it's a good chance, especially now, that you will get COVID. But you know what? Full transparency, I lost my best friend at the age of 38 to COVID, right when the pandemic started. And I sure wish he would have had the opportunity to get vaccinated, right? And so just being able to have those type of questions, have those type of conversations and be transparent in the fact, right? And so that's, where I come from, with it. And then also, through the work that we do with Community Grand Rounds, which is a program that we run out of University of Chicago in partnership with many of our community members, it's providing opportunities for our community members to have these honest conversations with experts that are just not affiliated with our institutions, but experts that are within our communities, and have these conversations and providing resources and being a resource for them to continue to ask questions, whenever they have them around this particular topic.
Thank you so much. And I'm so sorry for your loss and for the so many rich insights you just shared. That's absolutely, thank you so much. I'd like to hear from Joe as well on health equity implications.
Yeah, I'm going to pick up on something that Dr. Robinson talked about, and that was the shooting in Buffalo, New York that happened over the weekend. It's ironic in some sense that the following day there was another mass shooting in Laguna Woods, California at Geneva Presbyterian Church. And that was of Taiwanese Americans. So as we talk about this issue of health equity, we also have to acknowledge the fact that some people may not even be interested in this issue of health equity. Probably the people that are participating in this webinar are those that are interested, but we also have to accept the fact that there are people that don't think there's a need for health equity, and that this country would be better off with certain people not being in the country, period. So while I'm speaking to the choir, I think it's important also to pick up on this issue of trust. And once you lose trust, it's hard to rebuild trust. So our problem is there's been historical distrust of institutions, government, and individuals. And how in a climate like that do you build trust moving forward? And so the most important thing, and that is to meet people where they are and really get a better understanding of these communities, why they may be as angry as they are, why they are reluctant to do certain things, And also I want to throw in something that occurred to me before this talk began, and I think it's important to bring up now, that not only are we dealing with misinformation, there's a lot of disinformation out there as well. And so people are trying to figure out what to do in a climate where we not only have misinformation that's just incorrect information, but we have people deliberately spreading information that's not correct. So how does one make an informed decision when you're dealing with a lot of information and facts? I also went back and looked at it and found out that in a Meet the Press interview on January 22nd, that was a time that Kellyanne Conway introduced this concept, alternative facts. So we're also living in this age of alternative facts where if I present someone the facts that I know, and even if they're evidence-based, people come back to me with the facts that they've heard of and say, well, I've got these facts and they dispute your facts, so I'm going to go based upon the facts that I have. So there's a lot of noise out there, and we have to be aware of that. But the big thing is back to trust and building trust in communities and meeting people where they are.
Thank you so much for that. And this issue about trust, I also going to bring this back to our speaker, Dr. Perlis, that there's issues around kind of the American libertine streaks that exist out there in general, right, that go a long way back. And then there's historical injustices driving a lot of mistrust. And then there is, ever since 2020, there's been one absolute disaster after another. I wonder, can you kind of put it all together to get a sense of what's driving this? And clearly there's a lot of things, it seems like, but layering on top of that is an epidemic of depression, and it's disproportionately hitting people working on the front lines and people of color. So where do we go from here if we want to think about implementing good information? What are some thoughtful ways we can approach everyone equitably to get towards that goal?
So I think each of the panelists in different ways raised the issue of trust. And one of the things about trust is, unfortunately, another American streak is we like quick fixes, right? We love, the miracle drug or the miracle diet, and trust is not something you build overnight. And so I think one of our problems during COVID is you can't just go into a community and say, no, you should trust me, I'm a doctor. It's a process, and I think our opportunity now is in the same way that, COVID taught us we need to stockpile masks and we need to, plan ahead. I think we need to plan ahead and start the effort or continue the effort to build trust with communities, recognizing it's not going to pay off next week or next month. Trust is something that takes time. It takes the right messenger, the right community, the right message for a given community. So unfortunately, this is not a quick fix or a one size fits all. It's a let's invest in figuring out how to get the word out in the most efficient way, and build trust over time. So I think that's sort of a common theme here.
Thank you. In terms of policies in the future to get there, to make the investments in community engagement and information, I guess knowledge, evidence-based knowledge sharing, are there thoughts about what the local, state, federal government might be able to do to try to increase knowledge in ways that are respectful and build trust at the same time? I know it's a broad question, but are there policies we should be thinking about besides bringing on more mental health leaders into our government? By the way, it's not too late for the Biden administration to bring on a psychiatrist from Mass General.
I'll take a stab at it. One of the things that's happened during COVID is there's been a real effort to bring in community members as trusted allies that can go out and reach the community. So people have been hired as contact tracers, community health workers have been hired to go into the community and do work. But there's no real policy around that and who does the work. So if you're looking at policy, maybe there are opportunities to build off the experience we've had with COVID, to get the people that are living in the community, to create gainful employment opportunities for them, to actually go out and for lack of a better word, carry our water, because this is our message. It's not their message. They would be the messenger. And so it's unlikely that the community would kill the messenger in that sense. And it's more likely that they would be open to listening to the messenger when they came, particularly because the messenger might be someone that lives down the street from them, that they've known most of their lives. So there are some things that maybe we want to look at in some of our models in terms of who gets hired to do the work and who goes out and do the work. I know that public health has seen a largesse of money, but it's mostly to hire people to go out and talk to people about COVID. And so when that money's gone, who's going to be the messenger then? I mean, there won't be any money, and you need people to go out and talk about COVID. So maybe there's an opportunity to take a step back and say, maybe we want to continue to build off this informal workforce in a sense, and keep it going.
Wasn't there a large investment in contact tracing, hiring a lot of people in communities to do I'm just thinking if there are models AmeriCorps.
But as COVID goes down,
yeah,
the funding for contract tracing goes down because there's no need for contract tracers. Some of them are being, at some local health departments, they see the advantage in having those people there, so they're trying to create more permanent types of jobs and opportunities. But just like there's not a lot of money in mental health, there's not a lot of money in public health as well. So I mean, it's very difficult to make an argument for public health absent a pandemic.
That's so true, unfortunately. But even so, if we could come up with some policies that are really needed in the future to address misinformation, are there thoughts from the panel about? One thought there was having some community navigators or ambassadors or information leaders. Other thoughts, Natalie?
I would just second what Joe mentioned in regards to having community representation, right? That is key. And also, providing sustainable, income, right? So sustainable job opportunities for these community members that won't just go away once the numbers are going down, right? So that, I would agree with that.
Thank you.
Yeah, I can give a different example. It's a local example, and it goes around, it deals with the violence you see in Chicago. And I mean, there's been a whole industry that's been created just to get kids to school safely, where people are employed now just to watch kids walk down the street, help them get across the street and go to schools. So there has to be some will to look at some of these challenges we have and rethink what we pay people to do and what types of work is needed to get beyond where we are.
Thank you.
I think another, Mr. Harrington, I had written down, I was taking some notes about who is the messenger about when I was thinking about how to respond to this question about policy. So I was right there with you because that is such an important piece. Additionally, I think as we really are finally, which is long overdue, paying more attention in healthcare to the social determinants of health and how those really impact so many aspects of health and health equity, particularly. I think looking at policies around addressing these social determinants of health and population health, and what I envision is really seeing a partnership between the communities and our health systems. I think that's something that's been lacking in a lot of ways ways, unless you're kind of a traditional safety net hospital, that really was not in play. And I saw that play out early on in the pandemic, where there were many parts of the community that were not getting the resources that they needed. And this is before the vaccine. I'm talking about just access to testing and medical care when they needed it, when they were sick. And so that, I think we really need to take a broader look at thinking about tapping into the parts of the community outside of the healthcare
Yeah.
box of the hospital or the clinic, and kind of building these relationships so that we have a broader reach. And then also not only addressing COVID in that way, but also addressing some of these other social determinants of health. I think this needs to really be a partnership.
Yeah, real quick, going back on what Sharon mentioned, we have an example of that, right? I remember when COVID early on, when it started, and one of the organizations, that community organizations we worked with, had gave us a call, right? So it's one of our organizations that partners with us on our community grand rounds program. And, you know, many of the community members didn't have access to masks, right? And because we had that relationship, we were able to connect, right, that particular community member with, you know, a department in the hospital where they were able to provide over 5,000 masks to, you know, this particular community area, right? And so figuring out, you know, we do need to, you know, have our partnerships, but true partnerships where they can give us a call when they need things and we can provide what they need, not just having conversations, but being able to, you know, provide on the needs that they request of us, because we oftentimes come to our community members when we need them, in particular, when we need them around, you know, research projects, and we need, you know, to recruit research subjects, right? So in that partnership, it needs to be equitable for not only us, but equitable for our community members. And it was just, you know, that's just an example of, we were able to provide on spot, okay, you all don't have masks, you need 5,000, let's figure this out. Here's the pickup spot, you know?
Yeah. So these ideas about multi-stakeholder partnerships involving healthcare, the community, the business community, civic organizations, faith-based organizations, so many were stood up in response. And there was a report from the Kennedy administration 60 years ago called the Folsom Report. It was Health as a Community Affair, and it had this idea of having communities of solution all across the country that would bring everything together and fund it. Didn't quite happen, but a lot of other things did happen, like community health centers. But that idea could be a policy idea, how to create this federation of partnerships between the community and healthcare. And so, you know, that might be something in the policy stream in the future. Are there thoughts, future translational directions that you could see this work going, Dr. Perlis? And where do you think this work's going to go from here?
So I guess I'll comment specifically on the mental health aspect of it, just because that's where I do the bulk of my work. I think we have a pretty good idea about the sorts of strategies that work for mental health in the community. So it's really not that we don't know what to do. It's that we don't really know how to scale it. And the resources haven't been there to scale it. And one of the encouraging things has been the administration has invested in block grants to state and local organizations. So the idea is, again, there's not a one size fits all solution, but let's make resources available and you can try to scale whatever seems to work in your community. But I do think, for example, COVID made it necessary for a while for most psychiatry to be done remotely. Most mental health care was done remotely. And something that people had resisted, and it's impossible, and you couldn't possibly take care of people over Zoom. Well, it turns out you can take care of people over Zoom, and quite efficiently at that. And so, you know, to me, again, it's not that we don't know how to provide good mental health care, it's that we don't know how to provide it at scale. and in a way that is sort of tailored to a particular community and that community's needs. So to me, the translational research is really, how do you figure out and scale the right intervention in the right community in a way that's sensitive to their history and their culture and their needs? And that's not going to be a one-size-fits-all solution.
Thank you. And how to, at the same time, develop trust, which doesn't happen overnight. And be skeptical.
Yeah, I'd like to offer something, and it's probably more so related to my role with Capricorn as co-leader of the Patient Community Advisory Committee. The big question is, when do you involve the patient? When you've decided what the research is going to be, what the research questions are going to be, and then you go to the community and ask, do you want to participate in my research study? Or do you do the reverse? Do you build the relationships, work with the community and the patients to develop the questions, and then go out and do the research? What we typically tend to do, a researcher comes up with a question and then knows they need to reach out to people that are willing to participate in the research to get that question answered. And then they can't figure out why people are not interested in participating in the research. Maybe we need to rethink the process and put the patient toward the beginning and the community toward the beginning, as opposed to going to them when we need something.
Amen to that. Thank you. Okay. Well, at this point, we're gonna stop there with that point, and I want to thank so much this amazing panel that came together today, and Dr. Perlis for your brilliant presentation. This has been such a thought-provoking and rich discussion, and I feel like I need to have a whole seminar series on this alone. I'm learning from listening to all of you, but I appreciate so much your very thoughtful and authentic responses to this complex issue. And the work you presented today makes clear that there is quite a bit of misinformation, and at the same time, piling on top of that is an epidemic of depression, mental health issues, somewhat overlapping, but certainly not causative. And it really boils down to trust, and at the heart of all of this, and that there are a lot of bright lights in the future, potentially ways to learn from this, but hopefully we need ongoing investment and attention to all these issues, even when it's not across the front page of the newspaper, that these issues are going to be here for a long time. So I'm really grateful for all of your really wonderful comments, and thank you so much.
Thank you.
Right, so in the future, if you would have any comments on or questions for Dr. Perlis, there was an email address earlier there, but any questions or comments or concerns or suggestions for future seminars, please contact me. There will be an evaluation that will be sent out by email and a brief survey link, and we encourage you to fill that out. We do read those, and they do help us quite a bit in the future. We also have recorded this seminar, and although I had some strange video issues early on, I think we fixed those. This will be available in its entirety for you and your learners and colleagues if they missed the seminar on our YouTube channel. So I'd also like to thank Rachel for being my co-pilot and navigating through this presentation. And if you have any questions, please reach out to us. Okay, well, thank you all very much indeed. And we'll see you again in September, September 20th at 3 o'clock for our next Outcomes Research Seminar. And I will send out information about that shortly. Okay, enjoy the rest of your afternoons, and thank you so much.